All right, welcome everyone. It looks like a good number of us are here. So I'm Leslie Friday. I'll moderate our discussion today. I'm the Director of Content here with the Marketing and Communications team at Partners in Health. And welcome to PIH's annual State of the Organization briefing. It's hosted today by the Leadership Giving Society. And I feel very lucky to be sitting here with Sheila, Marc, and Katie. And I'll give everyone a formal introduction in just one moment. But we'll do a bit of housekeeping before we get into the presentation. So if you have not attended a Zoom meeting recently, congratulations. But if it's been a while, just go up to the view options and you'll see by clicking the down arrow side-by-side mode is the best way to view the presentation today. You can also increase the size of the slides. If you go to the far right, you'll see a parallel vertical bar, and you can move that left and right to increase slide size. We will be recording this event today, so if you know someone who wanted to see it or you can't see all of it, you'll be able to catch it later or share with others. There's also a closed caption option. So if you go to the bottom right hand of the screen, you'll see the CC there. You can just click that and choose whatever option is best for you. All right, I think that is the basics here. Welcome again. This event is hosted by Leadership Giving Society, and thanks to everyone joining who is a member of the Leadership Giving Society. And for those who are interested, this is a group that honors individuals who really champion PIH's work, and they provide unrestricted support of $1,000 or more annually. So if you're interested, please do reach out. I believe there's information in the chat available for you. So without further ado, I want to introduce our panelists. Today we have Dr. Sheila Davis. She's the CEO, Chief Executive Officer of Partners in Health. Welcome, Sheila. We have Marc Julmisse, who's the Interim Executive Director in Zanmi Lasante in Haiti. Welcome, Marc. And we have Katie Bollach, who's the Executive Director of Partners in Health United States. Welcome, Katie. All right, I will hand over to Sheila here, and if you have any questions, there'll be a Q&A at the end that I'll moderate, so just drop your questions in the chat section there. So go ahead, Sheila, and thanks for being with us.
Thanks, Leslie, and thanks so much for all of you being here today, and particularly to those of you who are in the Leadership Giving Society. We really value your ongoing partnership and always come along with us and hearing about our important work. It's always so challenging to choose what to talk about because our 12 country sites around the world and our coordination site here in the US is everyone's working so hard on delivering many aspects of care as well as running universities and so many other aspects. So I've chosen a few of the key ones to talk about today. And then obviously we're happy to provide information, more specifics on anything that you have would love more information on or would love more specifics. But I'm going to talk about today about the breaking ground that happened this past April at the Maternal Center of Excellence in Sierra Leone, give a little bit of an update on our global and domestic COVID response, including our advocacy for vaccine equity, which is something very important to all of us, obviously, as a core part of our mission. I've asked Marc Julmisse to give an update on our short-term and mostly our long-term efforts around the most recent earthquake in Haiti. And some of you may not know Marc yet, but she has a longtime PIH person, dear friend, who has been named the Interim Executive Director of Zanmi Lasante in Haiti. So we're very excited to have her here. Also very excited that Katie Bollach is joining us to hear about our recent transition from our COVID work in the US, which we were calling the US Public Health Accompaniment Unit, or the US POW. And now we've recently formalized and decided that our commitment to working in the US will continue. So we've changed the name to Partners in Health in the United States to be more in line with our other sites around the world. So for the Maternal Center of Excellence, in April, we broke ground, and this is we call it the MCOE, and it's in Kono in Sierra Leone, which is one of the places we've started working in during the Ebola outbreak in 2014. And what we saw while we were there fighting Ebola was that, Ebola was just a symptom of a really non-functioning health system. So the maternal mortality was extremely high, continues to be extremely high in that country. And that's one of the main areas we're focused on since 2014. And we know that there needs to be a flagship facility in Sierra Leone to really look at maternal and infant health. So we're building a 166 bed state-of-the-art maternal health and teaching hospital as part of the existing Kono District Hospital. And this is a place where women have a 1 in 20 lifetime risk of dying during pregnancy-related or childbirth. Obviously a huge issue. And while we've been there, we certainly have lowered the maternal mortality related to people who get to us at the facility, and we're still working in the district hospital, but know that there needs to be much more of a larger effort and a larger program, and the ability to train people not just for Kono district, but for the entire country of Sierra Leone and the entire region. So we're very excited about this effort, and not just for the people of Kono, but for what it represents throughout Partners in Health as are taking a stand against needless maternal deaths. So an important piece. Another part of this is going to be the region's first neonatal ICU unit. And this is really so tragic that this will be the first. We're excited that we'll be able to provide this, but something that's long overdue. And we know that Sierra Leone has one of the highest infant mortality rates in the world as well. So another place where we will be putting our efforts. And this facility will be, construction will take different buildings will happen over a number of years, and it will be the first part will be officially open in 2023. But we're already doing this work, and this work is just happening currently at the existing hospital. So we're very excited about this new expanded state-of-the-art facility, which will be able to provide much better, higher quality care. Exciting in Sierra Leone. And COVID care, sadly, we're talking about this, 18 months later, but we've continued to work both in the US and obviously globally at all of our sites. COVID impacts daily care and daily work. And we're partnering with our government and local partners on where can we help fill gaps around the needed pandemic response. We know that there's, increasing impact on supply chain around the world, and certainly our global sites are suffering even more so. But we're trying to increase access to supplies, building oxygen plants, trying to do what we can to get the much needed oxygen that certainly COVID has illuminated this gap that existed prior to COVID, but COVID has made much worse. We know the overall goal of combating COVID is obviously having a resilient health system. So even in our emergency response, it's always couched in how are we building and how are we strengthening the health system, not just during a time of emergency, but long term. Overall, we've done millions of symptom screening, hundreds of thousands of COVID tests, worked with our ministry partners and provided COVID tests for them, many supplies for them, as well as provided direct care for people who have COVID around the world at all of our sites, and also address the much needed social support. We know that when we're asking people to quarantine or isolate away from others, that it's critical that we care for the family in terms of food and water. And that's an important part of the care we do every day for whatever we're doing, but have really advocated that this be part of a global COVID response in the US, as well as at our global sites, since you can't separate out those core components of food and water and basic needs. In Lesotho, we used our COVID funding to build an oxygen plant, and this is actually providing oxygen now for the entire country and the hospitals that serve the entire country. And in Socios and Salud, or PIH in Peru, the oxygen demand grew to over 300% more because of COVID. And this continues to be a huge challenge, and so many deaths have been attributed to lack of oxygen. And this is something that around the world, but particularly in Peru, our team has been focused on. We're also getting our staff vaccinated where we can. Very disappointed, obviously, with the global vaccine rollout, but doing what we can to ensure that our staff and most vulnerable patients do have access to vaccination. But that's an ongoing push and an ongoing need as we continue to see this really gross disparities in where vaccination is possible. We just speaking on that, we know that we're very lucky to be in a country in the US where we're talking about numerous boosters for people, but there's still places in the US where there's not equitable vaccine access, or we know that there's certain communities that have a lot of disparity. So you'll hear a little bit about that from Katie Bollach in a few minutes. But we know that on a global scale, none of us are safe during a pandemic until everybody in the entire world has access and has vaccinations. And an important piece, our partnership and advocacy team is really pushing on a global scale, certainly very active within the US system as well, to really encourage and push our government to be able to ensure that vaccinations are being given to other countries, and that we're also really fighting for a release of intellectual property and patents that have prevented vaccines to be developed in other countries. So a complicated but an important piece of our work. And we're part of a coalition called the People's Vaccine, which is continuing to push on this, and something that, again, as a core component of us believing that the global health equity is the key, that we're prioritizing this as something we're continuing to try to partner with our ministries to get access, but also really push on the big picture of the United States and Europe and other places that have dominated taking and utilizing all of the vaccines, which is really unfortunate. COVAX is a global initiative on vaccination and has been somewhat successful, but nowhere near to the point it needs to. So we're continuing to also support COVAX as well as any other mechanisms that are available for vaccine access. And an important piece also of vaccine access is not just the drug itself, but the syringes, but the supply chain, and a lot of the other pieces. So also pushing that as we look at the world, looking to see what the gaps are in countries being able to have enough vaccines for their populations, that we're also looking at the full picture of comprehensive care. We know in places where we work that we have much more successful vaccine rollout because we have comprehensive care models with community health workers who are doing education about vaccinations, where we have a full comprehensive care so that people are willing to get vaccinated because they're part of a community of health systems and a community of care. And that we know is the best way to prevent pandemics is by having comprehensive, strong health systems around the world. So an important piece of our work will continue to be in this area, and certainly hope all of you are also aware of all that's happening in this. And we have quite a bit of social media push, and our partnership team and advocacy team, as I said, has been a strong leader in the US and globally in this effort, of which we're very, very proud. The Partners in Health, US, as I alluded to at the beginning, and really an example of where we stepped in to fill a gap, first in Massachusetts when we were asked to set up the contact tracing program in Massachusetts. And then we're called upon by so many different jurisdictions and states for the expertise from our experts around the world, which are people from Haiti and Sierra Leone, Rwanda, Liberia, et cetera, on how do you do a comprehensive contact tracing, vaccine, virus testing, vaccination. And we really saw that our experts could, the models that we developed around the world could really be applicable in the US. And we're very excited that that work has been done for the past 18 months. And now that we're continuing and using this bridge to really highlight where we need to have a more comprehensive model of public health here in the US, drawing on expertise from around the world. So I'll ask Katie to jump in and talk a little bit about our US work.
Great, thanks, Sheila. So as Sheila said, over the last 18 months, we've been rapidly scaling up our support to public health departments, to community organizations and community leaders across the US. We've worked with leaders and communities in dozens of states, cities, counties across the country that have been hardest hit by COVID, helping to stand up contact tracing programs. We've reached more than 80,000 people with social supports. We've massively scaled up over the last 9 months the vaccine access and uptake programs that are really facilitating, breaking down barriers that folks might be experiencing to be able to get an appointment or get to a vaccination site early on when there was high scarcity and limited availability of vaccination sites in hardest hit communities that needed them most. So at this stage, we've also been reaching a broader and a more expanded set of communities with our outreach and engagement programming through a federal grant that's allowed us to really invest and move money to frontline community organizations who have been doing the work, are trusted messengers, well-known in communities who have been able to really house by house, block by block, community engagement by community engagement, answer tough questions and break down barriers, accompany folks to vaccination sites to ensure we're seeing greater equity in vaccination across the United States. As Sheila and Leslie mentioned, we were so thrilled to officially make this transition over the last month or so from the public health accompaniment unit into Partners in Health United States to continue to help lean into PIH's global mission here in the US of ensuring that health is truly a human right, not a privilege or a commodity for those who can afford it. Of course, the US is a very different operating environment in some ways than other places we work around the world, but unfortunately, we see the same patterns of deep inequity in our systems, systemic racism that's driving deep inequity in health outcomes and well-being in communities. Driving 10 miles from a wealthy white community to a neighboring community of color and seeing a 30-year drop in life expectancy is simply unacceptable and something that we're committed to working with our local partners to really address the underlying root causes of the inequity we were seeing so severely during COVID in communities of color, working class and poor communities in the United States. Our work and our approach, as Sheila said, is built standing on the shoulders of the wisdom and experience of our teams around the world who have been building health systems, accompanying ministries of health and communities over many decades to build stronger, more community-based and equity-driven health systems. So we've been incredibly privileged to have leaders from Haiti and Sierra Leone and who've worked in our programs in Malawi and Liberia, now accompanying folks in Florida and North Carolina and Montgomery, Alabama to build out community health systems that are really built to serve the most vulnerable and those in greatest need here in the US. So in this next phase of work, we are really focusing in and committing to 7 communities who have invited us to accompany their work beyond just the acute COVID response and where we feel like we have really like-minded visionary partners from public health departments, from communities who really want to run together in advancing a broader health equity agenda to really address those upstream and systemic issues, again, that led to such horrific disparities in COVID outcomes here in the US. So those focus communities include Newark, New Jersey, New Bedford, Massachusetts, Montgomery, Alabama, Chicago and Cook County, Illinois, North Carolina, Immokalee, Florida, and Pima County, Arizona. I think our commitment as we do globally is to work deeply accompanying those communities, but also ensuring that we're taking lessons learned, insights, evidence, and really trying to drive national policy change and really shift the national conversation here in the US. We feel like this crisis is really an inflection point for us to take a much harder and closer look at those, again, deep and long-running inequities in our systems that we know are urgently needing reform at a local and a national level. And so we've been so thrilled to get to build on the incredible work of our global policy and advocacy team to really push to ensure better, in the short term, COVID, more equitable and anti-racist COVID funding and programming from the federal and state governments, but also really looking longer term now at how do we build a longer term runway for expanded community health worker programs, for stronger sustainable funding for public health departments who have been living on a panic and neglect cycle for decades and suffering systemic cuts for decades. And so looking forward, those are our kind of focus areas in this next stage of the work. There's of course continuing COVID work to do, and we're going to continue to run alongside partners and accompany their emergent and evolving needs in the vaccine rollout, in planning for a COVID endemic world and an ongoing sort of set of mitigation policies, but really recommitting to that community health worker set of programs and efforts across the country, and thinking about some national policy campaigns and efforts to really expand sustainable funding mechanisms for community health work and health departments, as well as continuing to build the collaborative infrastructure between the public health departments, community organizations, health systems. Our country is so deeply fragmented in our health systems, and we've seen some really exciting new areas of collaboration around a focus on health equity through COVID that we have a real opportunity to continue to build on and leverage in this next stage of the work. So again, just so thrilled to get to do that in deeply in collaboration with our colleagues from around the world, and to bring the incredible insight and wisdom of our work over many years here to the US, where it is sorely needed, as we've seen very acutely through the COVID experience here in the US.
Thanks, Katie, so much. And thanks, obviously, for your leadership. Katie worked with us closely in Sierra Leone during the Ebola outbreak and was a critical leader there. So we were so excited that she was able to help provide leadership and lessons learned and really drive this work for us here in the US. And now I'd like to shift to Marc, and one unforeseen pivotal event that happened this past year, recently, was the earthquake that happened in Haiti. So would love for you to share a little bit about that and what PIH is doing.
Hi, good afternoon, everybody. And thank you so much, Sheila, for giving us the opportunity to share with you just about some of the works and some of the challenges that we have here. As many of you may have known, in August 14th, we had a 7.2 earthquake that struck the southern peninsula of Haiti. We had at least about 30,000 families were left homeless at that time, and about 2,000, a little over 2,000 people died as a result of the earthquake. I am happy to say, if there's something happy to be about, is that we were able to be present on the ground. Within 48 hours, we were able to have our physicians, our nurses, our surgeons, our OR personnel, our OR staff, anesthesia support within the disaster zone to help with the earthquake. Several of severely injured patients that were within that zone, if they weren't treated right, they were able to get airlifted to our hospital in Mirbalais, which, and this is also due, we're not going to go into political issues, but also due to some of the situations that happened, they were able to get them lifted to Mirbalais. Our team were providing care not just in the earthquake zone, but also in this holding area in Port-au-Prince and also at Mirbalais Hospital. We supported many of our partners, our MSPP partner, our other partners on the ground, other organizations on the ground, some of the hospitals that were very severely affected in the earthquake zones, with materials, oxygen supply, with technical assistance, actually, virtual technical assistance, especially a lot of their equipment was destroyed by the earthquake specifically or damaged. And how can we help them or find other solutions? We also supported food supplies in the earthquake zones. One of the things that we saw with the earthquake and that made it possible for us to do this support is over at our hospital, HUM, or L'Hôpital Université de Mirbalais, which is an internationally accredited 300-bed teaching hospital. We in building this hospital, the hospital functioning, what happened out of the 2010 earthquake? I'm not sure if you guys were aware of that or no, from what happened in 2010 earthquake and the response that we had for them, or the ability to respond, is completely different to what happened in 2021 earthquake and our ability to respond. That investment that we made in this facility, where I am actually today, right now, in the facility, in training our clinicians, proved really crucial and really important to how we reacted or how we were able to intervene in this recent earthquake. Our graduates from the program here at Mibale Hospital were actually employed by other hospitals within the South. We're on the ground, we're starting to provide treatment for patients. Our graduates from the residency programs and our ED residency, our surgical residency program, were here at the hospital ready to receive the really critical patients to provide surgical interventions for them. And this is something that we can say that we're really proud of, that as we invested in the long-term vision, as we're investing in the short-term response, but also long-term vision, we're able to give a better response than what we were able to do in 2010. As you know, we are not a disaster organization, but we did work to repair our emergency response and continue to work on repairing our emergency response. And with our longer-term commitment and really looking at how do we strengthen the health system, our focus was on not just building a facility, not just training clinicians, in that is actually how do we work together within the system, within the MSPP, with our other partners in order to look at how do we really strengthen that health system and strengthen our emergency response there. Right now, what we're going to talk about is our long-term response to this earthquake right now. Sorry, we have a little fly. Our long-term response to this earthquake right now and is what we're doing now, and similar to what we did back in 2010, is we're looking at the short-term response. We have teams out there. We are supporting teams on mobile clinics. We're continuing support with psychological support. We're continuing to provide care for patients that are affected by the earthquake. But because they have lack of clinics over there, we're supporting our teams down there to continue providing some care. But we're also looking at some of the long-term plans that we can to reinforce the healthcare sector, or in that we're looking at what we did notice is, and what was shared with us, was the lack of anesthesia supply or anesthesia providers. So we do have, HUM has invested several years ago in a CRNA program. So we have the anesthesia training here. We are investing in more trauma training. We're investing in a new orthopedic surgical residency here in the hospital. To be able to provide some of the care to a country that is very prone to disasters. We are providing right now emergency nurse practitioner training program so that we can have people that are able to respond to the disasters again. We have OR nurses training program, because that was actually a lack, because one of the big things when we had our surgeon, our orthopedics, and some anesthesia, one of the biggest part was we don't have OR nurses trained in orthopedic surgery. And so now we're building that. We're having a certificate out there. We're looking at all these cares, because it's not just about, for us, looking at the short term, but really looking at what is that long-term impact that we're going to have so Haitians can treat Haitians. I'm going to pass this back over to you, Sheila.
Thanks, Marc, so much. And again, this is all in the backdrop of regular care of thousands of babies being delivered, of people receiving regular vaccines for our regular pediatric care. So I think all of this, the earthquake response, is certainly on top of and integrated as well into this backdrop of COVID and this ongoing care to strengthen the health system. So thank you for that. There's so much that's to be proud of in this past year and this challenging year, and it's I didn't get a chance to talk about the 10-year anniversary of the amazing work that's done by the Compañeros en Salud team in Mexico that is providing care in Chiapas and really building phenomenal models of care embedded into communities, and also our strategic plan launch and so many other things. So again, wanted to just touch the surface on a few of the key things, but much more information is available, and happy to provide anything that's needed. So grateful for so many people who help make this work possible. And there's so many partnerships, so many donors, so many people who have been with us long-term, and also people new to PIH are essential for us to be able to do this transformational care around the world. I'm going to pass it over to Leslie, and I think for some questions.
Great. Thank you, Sheila. Thank you, Katie and Mark. This is really great and a wonderful way to kind of set the table, I guess, for the discussion that people have waiting for you here. There are already some questions in the chat, but if you would like, please add more as we go along. I think the first question, Sheila, I want to direct to you is actually from Barbara, and she'd asked, what do you think of the argument that COVID vaccine manufacturing is too complicated, quote unquote, to export, and that the best route for the world is donation of doses? Is that just typical first world thinking, and what's your take on that?
Yeah, it is. Unfortunately, it is typical, I think, first world thinking. And we know charity alone is not going to stop this pandemic or the next pandemic. So, it's the intellectual property patents are a piece of it, but there's also transfer of the technical know-how, the biologics that are needed. But this can be done. There are places around the world that certainly have the capabilities to be able to manufacture vaccines. Had we started this a year ago, when it was clear that vaccines were being fast-tracked and that the US was close to having them to be approved and available, that's when, or even before that, we should have been investing and building manufacturing capacity in other parts of the world. There's certainly, we have examples of other vaccines that are manufactured in other places. We know that certainly it can be done. There's certainly the intellectual capability. There's the systems that are there. It just is going to take a effort and a will, and also a big push, I think, to push the pharmaceutical industry to say, you have to participate in this. Most science, as we know, is the result of public funding. And whether it's for specific vaccines or not, we know that that's a part of our public good and our responsibility. So it definitely is charity alone, we know, has not worked so far and is not going to work for this. So we certainly have to push doses out now as we can, but we need to be investing now, if not a year ago, on this manufacturing, and there is the capability to do that. Thanks for that question, Barbara.
Yeah, that was great. Katie, I want to ask the next question to you, and this is kind of a mashup of two questions, one that was posed in the chat by Linda and one that was submitted beforehand. And there's real curiosity about, someone had mentioned Chicago beforehand, but other US cities, and maybe if you could share specifics about the work and the impact that we're already seeing. One person who had mentioned Chicago and the community health worker model specifically, if you could speak to that a bit.
Sure. So in Chicago, for example, we were initially invited in through a local collaborative of partners, including some local philanthropy organizations who had been putting together this group of health providers, community organizations, local health department leaders who had started to meet to talk about preparing for the vaccine rollout in the city and ensuring there was going to be an equitable strategy and approach to doing that. And so while we were initially, invited in to help essentially support project management and coalition building in the city to bring this diverse coalition together to work against a shared strategy, it's allowed us to help mobilize millions of dollars in support to help then move through to those frontline community-based organizations. It's also meant who are out day to day running vaccine clinics, helping do door-to-door engagement and communication and referrals, knowing that when you knock on someone's door to talk about, have you been vaccinated? Do you have questions? There's going to be a whole other set of issues folks are struggling with that frontline workforce needs to be prepared to engage on and support and accompany their neighbors, community members on. But that has led to a broader set of conversations with the Chicago Department of Health, who already had in the works some really ambitious and exciting ideas about health equity zones and thinking about kind of really trying to reconfigure how decisions are made and sort of power dynamics in neighborhood by neighborhood organizing and strategy building around health equity. And so we've been so thrilled to be invited to sit and support that work, as well as advisors, as accompagnators to the community partners, to the health department, and excited to see that work grow. I think that's looked a little differently in a place like Immokalee, Florida, for example, where we were initially invited. It's a rural community in Collier County, which is a very wealthy county in Florida, but has a large unincorporated area that's mostly migrant farm workers in this community of Immokalee. And so have been working there with a federally qualified health center, with a local incredible human rights organizing group called the Coalition of Immokalee Workers, as well as with the Presbyterian Church, and basically built a coalition that could work together to ensure migrant farm workers had access to testing, to COVID vaccination, had a referral pathway to care at the health center, and also were able to mobilize a cash assistance fund. We initially put in $50,000. We're ultimately able to raise more than $800,000 together with other partners to ensure that migrant workers who would otherwise have to stay home to isolate or quarantine, unsupported and unpaid, to be able to give some cash assistance to help folks take care of their basic needs, families, during a period of isolation and quarantine. That's then opened doors to working with the county more broadly. We helped co-write a CDC grant that's now going to build out that community health worker program for 2 years in the community, and that will continue to do COVID work, but support more broadly the comprehensive needs of a community that's been disproportionately impacted by all sorts of structural violence in Immokalee over generations. So, we think that, as in our work around the world, the community health workforce and community health workers are the backbone and the heart and soul of an effective and equity-driven health system. And we're just really excited. That's going to look very different in Chicago than in a community like Immokalee, but to really adapt that approach and run alongside partners to achieve the expansion of that workforce and investment in that workforce for the long term. So I think I touched on a few pieces of that question, but feel free to redirect me if there's anything key I missed there, Liz.
No, that's great. I think that's great. Marc, I want to bring you into the discussion too. And I noted several questions about security. We just wanted to say generally that for staff safety, we can't be specific, but that everyone is taking the utmost precautions in Zanmi Lasante and in Haiti to make sure staff and patients are safe. So Marc, there was kind of a logistical question submitted beforehand that I thought was interesting, and having sat in on calls about our Haiti response or earthquake response, I think it is interesting. How do you get supplies from ZL to the earthquake area? How do we go about doing that? It's kind of a multi-pronged effort from what I understand.
Oh yeah, I think one of the biggest thing is it's really, it's multi-pronged, very much so. Just touching a little bit, we do know that some of the avenues that normally would be available to us were ground transportation because of some gang activities that has severely limited our ability to do ground transportation. So we are counting a lot on partners and collaborating with a lot of people to see if we could do air transports across. We're looking at barge transportation, as many options as available. Immediately after the earthquake, we did a lot of air transportation. We had, and there was a ceasefire for a period of time where we were able to get quite a bit of materials across, but onto both ends, it's trying to see how we can really invest in other areas. Really, you're looking at most likely air transportation to get it down to the south. In areas, there's some people that do take the risk, but we really don't encourage that to try, because we really want to protect our drivers as much as our other staff members too.
Great, thank you. And this next question is for Sheila, and it's related back to vaccinations, global manufacture vaccinations. Richard asks, building plants around the globe to manufacture vaccines is a multi-year endeavor. Where could Big Pharma license manufacturing to boost distribution more quickly and effectively?
Yeah, I definitely agree. It is a multi-year process. That's why we're advocating certainly advocating that there is donation and charitable push for vaccines that are manufactured in the U.S. now to places around the world, but also that we know that, as we should have started this years ago, we need to just make this commitment to start the manufacturing So there's, the People's Vaccine, as well as a lot of other groups who have put together plans and have laid out ways and options of how this could be jump-started and fast-tracked, building on existing systems that already are existence in certain places. So I think there are ways that this can be started, but it's I think the intellectual property piece is one that we've all talked about quite a bit, but knowing that that's just one piece of this puzzle. So there are plans that are laid out that from certainly people who are this is not my expertise, but others, but have been advocated for. And I really suggest that people look at the People's Vaccine website, and it has a lot of the information and a lot of strong work done by scientists around the world who are trying to really show where this can happen. And I think that this can be made a reality, but as you said, really appropriately, this is a multi-year process. And whatever expertise is being built in this type of vaccination of the mRNA is certainly, we know that there's going to be other pandemics, other needs for vaccine development beyond just COVID. So this is not an investment just in COVID response, but an investment in bringing this expertise and technology to other places in the world that desperately need it.
Great, thank you for that point. And there's another question, Katie, I think might be best for you this time. Wendy says, it sounds like there's been much expansion of PIH services, and she's curious, where's funding coming for this? Is it federal, state, local governments? How does that work? And then do you get the general sense that there is more of an appetite to committing to expanding public health services in the United States?
Yeah, great question. So we, I guess the short answer would be yes. I think with this crisis, it's really opened eyes in a different way in terms of the systemic disinvestment we had been undergoing in the US in public health, seeing year over year really gutting of staff and funding for core public health functions in communities across the United States. And so we've done a lot of advocacy and organizing work to really help influence the initial response funding, the American Rescue Act plan funding, which we're continuing to see move now through states and into communities. And so have been very active in helping support our local partners in tapping into those resources and really maximizing their access to federal and state money that's moving to support public health. That's also helped support some of our team and our work. So about 65% of our efforts are now public sector funded in the US through federal, state, or local grants and contracts. But there is still some time horizon on that. As of right now, a lot of that is a 2-3 year time commitment, which is a big leap forward and a unprecedented influx of new resources for departments and communities that sorely needed them for a long time. So we're really seeing this again as an inflection point, a moment that really has to be leveraged to deploy those resources as effectively and equitably as we can right now, but to keep our foot on the gas in the national advocacy fight to ensure that there is longer term sustained investment in public health departments, in community organizations to do that much longer term health equity work. But yes, at the present moment, I think the good news is that we are seeing that money moving and are really trying to support our partners in hardest hit communities in getting fair and equitable access to that, and ensuring it's also moving through to frontline community partners. But we foresee a mix, as with our work around the world, where we have public sector funding, the flexible philanthropic support that can wrap around that and complement that can be essential in continuing to be nimble and agile and being able to move, in a true and fully, accompaniment spirit. But we do see that public sector funding as critical anchor funding, especially in an operating environment, again, like the US, where there are resources in the system. We have tremendous wealth and resources here. They're just very inequitably distributed right now. And so we see our work as upstream, trying to affect and change that distribution of resources in our system.
Great, thank you, Katie. And Marc, I want to bring you back in too. There's a question here. I know that you've worked in the United States and now in Haiti for many years. But Marilyn asked, especially since COVID hit in the United States, one hears or reads about people who don't trust medical professionals and treatments, including in countries where we work, right? So I'm curious, because this question is interesting about, COVID, questions about COVID and vaccination, I think, are very different in the United States versus in Haiti. So maybe you could speak to that. What do you see in the work you do every day?
I'm laughing because I'm one of those people that's like, so I can completely understand a lot of people. And I think we have some of the similar issues that we're facing in the United States here. It's also is that fear and misinformation, really fighting a lot of misinformation. People have a lot of access to social media. A lot of things are passing on WhatsApp and all those other media, all of those other social platforms. But there is a big battle in fighting misinformation, but we also have a lot of people tend to go to traditional healers for care. So on top of that, they might agree that they have COVID or so forth, but then might not necessarily go for the conventional treatment, but might go for traditional treatment, which our thing, and this is not just for COVID, I think overall is saying, how do we work with the system in hand, not battle that, but working together to understand and making a collaboration together with the traditional healers and with conventional medicine in order to address the issue. And I think on our end, and this is not just for patients, I think there's also that battle, making sure that we have the right information being shared with clinicians across the board, so that and we have done, and something that I really appreciate, for years we do patient accompaniment or sensibilisation. So we work with community health workers to meet people where they are, rather than a presentation, rather than a flyer. It's speaking to you in the language that you are used to. It's not somebody from outside. I can't go to one of the communities because even it's regional. There's ways that you speak and get it. So the community health workers that work within the area that know that the local language, and local language not necessarily being Haitian Creole, but local to that area, and how to get the words across. So sensibilisation is not just about flyers. It's not just about posters. It's about how we actually get that information out. So we're working with that. We're working in the communities to really battle misinformation and really get the correct information out, and using real experiences that are happening to us in Haiti. And a lot of people are touched by it and understand their fear and don't just put it off. I think our big thing is just saying that's ridiculous. No, it's not ridiculous. We understand your fear. We hear what you're saying. Let's address it where you are. And we're trying. We're not 100% successful or 75%, but we're trying.
No, that's great. Thank you very much, Marc, for that. And this one I'd like to send to you, Sheila. It's from Connie, and she says here in the chat, I'm curious about the deliberation pro and con over moving COVID work in the US to PIH-US. So one of the reasons I give to PIH is its focus outside the resource-rich US. The US health system is inequitable and vast, and its political system is so skewed. It seems to me PIH's resources are better spent abroad, where its leverage is greater. So if you don't mind commenting on that question.
Yeah, and thanks, Connie. I think that's such an important question. So I'm glad you asked. When we were first asked to come to work, to work in the US, this is something that I struggled with, and we talked about with our board and with others, and really have committed that our work in the US would not detract from what we were doing globally, and have continued on that vein, knowing that, as Katie said, the resources here in the US are vast, they're inequitable, but really looking at leveraging the funding that exists in the US, and where can we be able to ensure that gets to the most vulnerable communities. So, we're not taking away from our global donors. We're getting new donors who are interested in combating inequities in the US health system. And also, as Katie talked about, really focusing on our public sector funding of the money that is currently exists. So I think we're paying really close attention to that, and still the vast majority of our work is global work, and will continue. But really see that another place where we can have influence is on funding our global work, is people learning about PIH. And they often learn about PIH because it's in, they're hearing about it from our US work. So an important question, and really glad you asked that. And just want to certainly say that our commitment certainly to our global sites is, first and foremost, but really see that we can play a role in the US as well. And really, I think, be able to show the expertise also that we have globally that we've been able to bring to the US. And really try to, as Katie said, and during this inflection point within this awareness of the illumination of the gap in the US system, we think our investment can be really targeted and really important now to make long-term change. Thanks for that question.
Yeah, thank you, Sheila, too. I'm just looking at time and mindful of everybody's busy schedule. So I've got one more question, and I think each one of you can respond, maybe in order of the presentation here. Sheila, then Katie, then Marc. John wants to know, and many people I think in general want to know, how can you help, right? So John specifically said, is there any role for retired medical providers to supply volunteer service for PIH initiatives in the US specifically, but maybe, let's throw it out globally. And, if you're not a medical provider, how can you help at this time? Sheila, if you don't mind starting.
Yeah, I think there's certainly, we look for people who can provide long-term support. I think for us, it doesn't work particularly well to have short-term people for a week or two, just because the nature, we have phenomenal clinicians on the ground in all our sites. But if there's specific types of skill set that you have and are able to make a longer term commitment, I think we're always happy certainly to talk to you. I think others, we're always looking for people to be able to share about what Parkinson Health does. And we have active student chapters around the country, and also in Peru and Mexico, which is exciting. So I think this is really a movement, and it is a movement towards global health equity. So everybody, I think, can play an important role. I think it's just figuring out what the best thing is and the best match for that. But we'll pass it over to Katie.
Thanks, Sheila, and thanks, John, for the question. The piece I'd add is just, as I was highlighting a bit, I think a big piece of our fight here in the US is on the advocacy front, and we need, all hands on deck in terms of folks who are willing to write letters, to attend, hearings, to write op-eds, to participate in really landing those key messages with our policy and decision makers, both in terms of the reforms we know we need within our US system, but also on that critical global equity, vaccine equity fight, and also the kind of fight to expand and change the way we do foreign aid here in the US. Yeah, I think there's a number of opportunities for our advocacy team. We'd love to continue to engage our broader community and PIH family in this next stage.
And I think I would add is it's somewhat of a mixture. Some of what Katie said is also to add to the point of advocacy, and the way it definitely is very something that we're building up even more so in Haiti, is that advocacy part of how we're receiving funding. So certain type of fundings, how that's distributed to countries such as Haiti. For volunteers that are clinicians that do want to help, like Sheila did say, longer term, because one of the things that we want to do is not just short term, but we want to see how we're changing systems. And in order to do that, that longer term helps understand what is going on within the country, within the context. Because even if you do know the country, that particular zone might have a different context. And it's, if we're trying to change systems, it takes a longer term approach to change a system than to make a short term intervention. And we have really great clinicians around here, and also definitely very open to collaboration and people bringing in ideas so that we're working together. So we do have advisory councils out there that we do welcome people to join in on them, but it would depend on what we're trying to build up. For instance, we're building our orthopedic services, we're building our emergency nurse practitioner services, which is something that does not exist in the country yet. It is very new. It is about 2 years old. And that is something that we want to build out even further, so that the point is to have people out into the more rural areas providing that level of care in the rural areas. So that is a program that we're moving towards to build. So there's quite a bit of things that we could share. And then depending on what your skill sets are or what your level of commitment can be, definitely we welcome people to work with us.
Great.
I hope that answered the question.
Yes, I love the variety too. Each of you attacked the question from a different angle. One thing that I would like to share, I guess specifically about Haiti, we're working on the annual report right now, and 96% of graduates from our medical residency programs remain in Haiti and work in Haiti, either with us or with another health facility in the country. So that's just fantastic and really speaks to that health system strengthening. So thanks to everyone who attended. I really appreciate Sheila and Katie and Marc taking the time out of your busy schedules. I also want to thank all of the folks who signed in and stuck with us through to the end. Please do share the recording. It will be available on our website. And while you're on the website, go ahead and check out news. You'll see many stories about our work in the United States and all around the world. You can also find us on social media. We're at Facebook and Twitter, Instagram. We're even on TikTok and LinkedIn. So check it out and help whenever you can. I know many of you are already donors, but consider, especially end of year, adding to that donation. We really appreciate it, and it helps us do the real work. So thanks, everyone. Have a wonderful week. And thanks again, Marc, Katie, and Sheila. Bye all.